Welcome. In this mini lecture, we're going to look at consumer relations. In particular, we're going to focus on supplier-induced demand and the asymmetry of information. So supplier-induced demand. The professional status of the physician and the doctor-patient relationships are rooted in the dual roles at which the clinician must perform. So the clinician acts as both the agent of the patient, providing expert direction and assistance, and the interpretation of the patient's health status and the identification of treatment for the patient. So due to the knowledge, the clinical knowledge, there's a mismatch of information. The consumer, the patient, doesn't have enough knowledge about their condition and the different types of care that they can get. It's up to the clinician to explain things, and this is what the relationship is. It's a professional relationship, but at the same time, it causes difficulties with our typical supply and demand. Now, if you think back to lectures 1 and 2, where we're looking and considering perfect competition, the medical model is definitely not perfect competition. So clinicians have a dual role in guiding the patient with demand for services, but also in supplying the services. So they do the two sides of things, whereas in the typical supply and demand curve, a doctor or the producer of a service would provide it, and the demand would come from the consumer who has knowledge about the product and has decided to buy it. This isn't the case with a clinician and healthcare. So a variety of market and institutional regulatory influences can provide doctors with incentives or disincentives to engage in supplier-induced demand, and we're going to talk about some of those. Substantial information asymmetry, so the potential for an imperfect agency relationship. The relationship is that the clinician has all the education, training and information, and the patient doesn't. So there's this mismatch of information. It gives the clinical uncertainty, which provides doctors with the capacity to engage in supplier-induced demand, whether consciously or not. However, these characteristics do not guarantee the presence of supplier-induced demand. It's just an opportunity that it could exist. We'll also see that systems for financing, organizing and paying for medical services also influence doctor and patient behavior. So a variety of market and institutional regulatory influences can provide doctors with incentives and disincentives. So substantial information asymmetry, potential for imperfect agency relationship, a system for financing, organizing, paying for medical services also influences patient behavior. So supplier-induced demand is more likely to prevail where consumers are free to choose their doctor. There is no contractual or employment relationship between doctors and third-party insurers, and doctors are remunerated on a fee-for-service basis. So they get paid for what they do. The potential for supplier-induced demand to rise is shaped by some characteristics of the medical markets that distinguish them from the competitive market. In particular, substantial information gaps and asymmetry of information, as we've said, potential weakness of the agency relationship between doctors and patients, and the impact of clinical uncertainty on doctors in the decision-making process. Clinical care doesn't come with a guarantee. It's not the way it works. So the clinical uncertainty is also on the side of perhaps supplier-induced demand. There is in fact considerable debate over the influence of these factors on the extent of supplier-induced demand. Research actually suggests there's no clear conclusion whether supplier-induced demand actually exists or not. So medical market characteristics, there's not a single homogeneous medical market, there isn't, but rather a number of sub-markets, including preventative, general, specialist, emergency, remedial medical services. So there's lots of sub-markets within healthcare, and they're not the same. The possibility of supplier-induced demand is likely to vary between the different sub-markets. So what research has shown is that there's different opportunities for supplier-induced demand to actually exist based on the sub-market. So in general, the scope for demand inducement is likely to be greater where the medical care is complex. There is significant asymmetries of information and knowledge, and the cost to the patient of obtaining additional information is high. So when it's a complex medical procedures, there's opportunities for supplier-induced demand to exist. To some degree, the scope of supplier-induced demand arises in any specialty market, where consumers have significantly less information than producers. If you think of motor vehicle repairs, financial advice, legal services, these are all very specialist services where the consumer has little information. If you look at just one example there, motor vehicles, who nowadays would have any knowledge of motor vehicles and how to repair them? They're electronic computers and so on. So you need a lot of equipment, and you need to know what you're doing. So we trust in people that they do the right thing. However, it can be argued that the combination of the distinguishing characteristics of medical markets and the extent to which they influence market outcomes that sets medical markets apart and creates more extensive opportunities for supplier-induced demand to occur. So the medical market is unique as it concerns the consumer's health, well-being, and sometimes even their life. So it's unique. A motor vehicle repairs, not the same. Might cost us money, but it's not about our health, well-being, and our life. So it's different dynamics. There's various models for supplier-induced demand. We've got target income hypothesis, the hypothesis that physicians and possibly others have a target income which needs to be fixed over time. Which need not be fixed over time. That their rate and style of work is adjusted to achieve given a fee-for-service, specifying a fee-for-service is provided. So in other words, they have a mental idea of how much their income should be, and they adjust their workload to achieve that income. And in this scenario, the additional treatment generated by the doctor is driven primarily by financial considerations rather than impartial assessment of medical necessity. Such additional treatment may, for example, be driven by a desire to boost their income or to stabilize their income. Again, it's a hypothesis. Professional uncertainty. The professional uncertainty hypothesis suggests that due to autonomy and individual practice patterns, physicians differ in their opinions regarding effectiveness, appropriateness, and success rate of various treatment options for a particular condition. So this leads to a level of uncertainty which may result in a lack of uniformity of acceptable standards of care that could be followed by all physicians. So the uncertainty may lead to different levels of recommended consumption for patients and healthcare. It's the professional uncertainty and the not knowing and wanting to be sure. Overutilization. Simple adage, if you build it, they'll come, can apply to supplier-induced demand in the medical profession. This can occur in hospital intensive cares, general practice, where overutilization of expensive technology and laboratory testing. Research suggests that those who actually invest in medical imaging equipment order more CAT scans and MRIs than doctors that haven't made the investment. Research has also found that physicians respond to receiving positive tests by actually ordering more tests, again, to make sure. Variation in medical practice can result in supplier-induced demand, without producing any increased quality of outcomes. So we're paying more for things, but for no better quality outcome. New technology. The advent of newer technology has not only led to improvements in care, but also the potential unnecessary screening and diagnostic testing, possibly influenced by financial incentives to referring physicians, practice behavior, referring doctors, and the health system itself. So it's been suggested that fragmented care processes, imperfect patient memory, and the lack of electronic patient records also contributes to the overutilized health services, but in particular the diagnostic testing area. As part of the hospital electronic patient records and the My Health records, this is part of what those two new systems rest on, that it's hoped that those systems will actually save money over time, because the more we use them, the more information they have, it will be on hand. We don't have to rely on patient memory of things. It will be there to be seen in records. So that's part of what those systems are built on, that we will save money in this area due to the records being easily accessed. No brief chat about supply-induced demand would be complete, I don't think, without raising Jeffrey Edelston, an Australian doctor. Jeffrey Edelston, a colourful person. You might care to, if you're not familiar with him, look on the internet. Jeffrey Edelston. He's a very colourful person. Unusual, colourful person. So have a look on the internet, see what you can find about him. Following the establishment of Medicare in February '84, Dr. Edelston began to run innovative and multidisciplinary 24-hour medical centers. They were decorated with chandeliers, white grand pianos, and mink-covered examination tables. The clinics attracted considerable media attention, as you can imagine. There was one here in Brisbane. There was certainly at least one in Sydney, if not more. Edelston's clinics were among the first in Australia to bulk bill patients to Medicare, so they incurred no cost. So bulk billing, patient comes in, sees the doctor, has various tests and so on. Everything is bulk billed to the government, fee for service. The patient paid nothing. Within 4 months of opening, the first clinic was dealing with 2,000 patients a week. Edelston eventually owned 13 medical centers in which approximately 20,000 patients consulted 200 doctors every week. I could actually find nothing suggesting that Edelston was over-servicing and he wasn't charged. I can't find anything saying he was charged with over-servicing and Medicare fraud. It's just something to look at and consider. However, Edelston was removed from the medical registrar in 1988 for using unqualified staff for laser surgery. Nothing to do with Medicare, but he was struck off the list in 1988. Ethical concerns of supplier-induced demand. We've got Medicare fraud that we've just talked about. Dr. Edelston was never, I don't think that I can find, ever charged with Medicare fraud, but supply-induced demand can be associated with Medicare fraud and can be a prosecutable offence for reasons that include conducting and billing of unnecessary procedures. So that is considered fraud if there are a lot of unnecessary procedures being billed to Medicare. That's fraud. The boutique concierge primary care, growing trend of boutique or concierge primary healthcare physicians who advertise more personal care can be viewed as an example of supplier-induced demand. Concierge medicine is based on an annual fee paid by the consumer. Proponents believe this model will increase the quality of care delivered to those individuals who subscribe. Opponents argue it creates a two-tier system with better care for those who can afford it. Having looked at this sort of care once before myself, the type of things that they suggest and provide for a fee, an annual fee, is the sort of things you can get through your GP for no cost whatsoever. So, supply and induced demand. So why does supply-induced demand matter? So if supply-induced demand was a common feature of general practice in Australia, the impacts of the community could be significant. For example, it could result in a higher than necessary share in the nation's resources being devoted to healthcare, and could lead to a deterioration in some health patients if treatment is inappropriate. So in other words, we're spending more money than we need to on healthcare if we have induced demand. It could also have an important implications in the conduct of the health policy. So, for example, if pervasive supply-induced demand would undermine the effectiveness of co-payments and price fee controls as a means of restraining restraining health costs. So it would actually influence and undo some of the work with health policy. Similarly, it would reduce the effectiveness of controls that limit the numbers of doctors. We're starting to demand more services than what's required. A bit like the Edelsten model. Yeah, a lot of information. So information asymmetry, we've looked at that, but a slide upon it here. Adverse selection is therefore also to do with information asymmetry. So information asymmetry theory suggests that sellers may possess more information than buyers, skewing the price of the goods sold. Okay, so that's very much in the healthcare market, where the people providing healthcare, not just doctors, nurses, allied health professionals, and so on, are all well educated, and the consumer has little knowledge. So there's a mismatch of information. So in conclusion, from an economic viewpoint of healthcare enables the identification of market imperfections. So in lectures 1 and 2, we looked at supply and demand. We looked at perfect competition. And we said at the time that it didn't exist, but it's a ruler to measure where other types of markets fall well short of a perfect market. Our clinical market falls well short. Supplier-induced demands, clinicians act as the agent for the patient, providing expert assistance in the interpretation of the patient's health status and the identification of what treatment is required. So that's very not like perfect competition. What perfect competition, one of the 4 cornerstones was that the consumer has full information. Well, in healthcare, the consumer does not have full information. The seller has full information. Symmetry of information, part of supplier-induced demand, or can be. Asymmetric information theory suggests that sellers may possess more information than buyers, skewing the price of goods sold, or can do. People can ask more for their goods because the consumer has little or no knowledge of the actual items themselves. So that's supplier-induced demand. Thank you for joining me.